Okay, welcome back. Almost to the very end of the semester. We are going to finish up talking about nutrition and older adults. So this is going to be part one of a two-part lecture series. It's kind of a long lecture slide. So I will quickly tell you the objectives. We're going to talk about a lot of physiological changes because a lot happens in the body as we age, and they have a pretty important impact on how they alter our lifestyle and our nutritional needs. The elderly are definitely one of our most vulnerable populations, if not the most vulnerable population, for a variety of reasons. So we'll spend a lot of time talking about objective number one. Along with that, all of the factors that put elderly at high nutritional risk for malnutrition and some screening tools to help identify high risk elders. We're going to talk quite a bit about those screening tools. If we were actually still meeting in class, I'd have you practice them and use them and kind of have a better understanding. Instead, we're just going to have to talk about them and make sure we know how they're used to assess nutritional status. Then we're going to end talking about some resources available to assist elderly with nutrition, and then some causes and dietary treatments of any age-related diseases that we'll review at the very end. Let me move this for you. See my moderately funny cartoon here. Oh no. Oh no. Sorry about that. Um, all right, that's a little bit better. Anyway, I was off to a rocky start, but we are talking about normal aging, and unfortunately, we're all going to age, and it's inevitable, right? The alternative would be to not get older, and I don't think anybody wants that. So it's inevitable. It is, for the most part, irreversible, and our body absolutely changes over time. It's hard to understand when you're a younger person. It doesn't seem like anything's going to change, or if it does, it seems very far away. But it does. It does happen. From personal experience, I would say I started to notice that I wasn't a young person anymore. Right around the midpoint, right around age 40. Um, and another thing that I have noticed is that healthy habits absolutely do help. There's many benefits. Hopefully you can think about them and think of quite a few of them. Certainly preventing chronic disease, it's not a huge concern of mine right now because I don't have any, but they make me feel better. They make me sleep better. They give me more energy. Um, I also can't tolerate unhealthy habits as much as I could when I was a younger person. Probably due to my profession, I'm a strong believer that healthy habits is really one of the most important parts to healthy aging. So my dorky cartoon here. Every day I walk for 30 minutes, I drink 8 glasses of water, and I eat 5 fruits and vegetables, but I'm still getting older. So that kind of gets back to that inevitable and irreversible aspect of the aging process. It's kind of an interesting discussion to have. If you ask a really young kid who's old, they would probably say 30 or something completely outrageous like that. You can kind of think of this the same way we talked about adolescence, that the chronological age, the number is somewhat meaningless. And with elderly, we certainly don't have an age that really means old. There's certainly some milestones. If you know what AARP is, it's a group, you get all kinds of discounts and they send you a magazine. American something retired persons. I can't remember what the other A is for, but that starts at age 50. Around age 60, it'll be kind of this universal senior discounts. The elderly nutrition program where you can get some free food, usually uses 60 as their benchmark. Social Security benefits kick fully in at age 65. And when they're taking the census, you probably know we're in a census year right now. We call 65 to 74 young old, 75 to 84 aged, and 85 and older the oldest old. But there's, again, no one common definition. I always get a kick out of that picture. Not that I advocate smoking, but also kind of making the point that um, we have the ability to keep people alive for a long time, and that's a wonderful thing. It's a testament to our good health care. It is a well-known fact that Americans are, living longer, aside from, current catastrophic events that are going on. On average, 13% of our population is over 65, and by 2050, which really isn't that far away, 20% of our population will be over 65. And persons over 85 are the fastest growing population group that we have. So people live longer, but if we still kind of use, 65 as when you retire, you can kind of think about what that means, and think about what that means for our healthcare system. Now we're going to get into the physiological changes. I always think the younger person in the mirror looks like Arnold Schwarzenegger. Um, but just a cartoon I pulled off the internet. This first physiological change is an important one, and it's the loss of lean body mass. So you think of lean mass as anything that's not fat, the sum of all fat-free tissues. So it's both minerals like our bone skeletal system, but it's also water and muscle because those are not fat. And in fact, all of those decline as we age. This is so significant that we actually have a term that was coined, oh, not terribly long ago, but the term is sarcopenia, and it means the loss of lean body mass associated specifically with aging. So that's how well defined this is, that we know that this happens. We even know by about how much. So we lose about 15% of our lean mass from age 20 to 70, so in that 50-year time frame. And if you think about what it's getting replaced with, what's left, right? If fat-free mass is everything other than fat, that means when we lose that, it does get replaced with body fat. So what will be the end result of these changes? Um, think about it. So when you lose your bone mass, what happens? If it's severe enough, you might start to see the spine curve, more prone to fractures and breaks. When you lose your water, you're more prone to dehydration. You feel the effects of alcohol sooner. When you lose your muscle, you can lose your functional status. Your metabolic rate will decrease when your muscle starts to decrease. Certainly, you won't be as strong, and it's also going to be more likely to have changes in things like your blood lipids and your blood glucose. So this loss of lean body mass, even though it happens, over a long period of time, it absolutely impacts our health. So a big message here is, we're going to lose our lean body mass, but we can slow it down significantly with weight bearing and resistance exercise. So if you want to preserve that lean muscle mass and even your bone density as long as possible, you really want to be physically active, right? You want to be the happy lady golfing, not the person who needs a motorized scooter to move around, and not the person who can't get out of bed. This is about not only healthy aging, that includes having a quality of life and being able to hopefully enjoy your older years and not have them spent going to the doctor all the time. In terms of weight gain, our mean body weight gradually increases with aging. right? We go through our growth spurt when we're teenagers. We don't gain in height anymore, but just about everybody gains in weight over the years. Most of us have our highest body weight between ages 50 and 59, so that decade. And you can kind of think about why that is. I think that there's probably sort of social and behavioral reasons why that's happening. We talked about how that's the sandwich generation. It can be the most difficult if you're caring for kids and elders and having still having a job that you have responsibility for. Um, Another kind of funny thing that happens with body weight is a lot of times we actually do start to lose weight if we get a disease state. Sometimes that's happens in our absolute latest years, and a lot of times body weight can decline significantly right before we pass away. So we seem to see this peak at between 50 and 59. Having said all that, weight gain is not inevitable. You can prevent it, but again, that physical activity becomes really important. So moderating weight gain, meaning that you're not going to gain weight as quickly or as significantly. It's also going to help with that body composition and keeping your lean mass up. And kind of thinking about where we gain weight. We know that having weight gain in our stomach is more harmful metabolically than if we gain weight in our hips and thighs. Other physiological changes, changes in our senses, these especially are going to impact nutrition. Oral health we might take for granted, but if you have difficulty chewing because of dental problems or swallowing because of, if you've had some brain damage and you've had problems with kind of coordinating that, it's really going to influence what you can and cannot eat. Often the most difficult thing to chew and swallow is our protein foods, especially our animal protein foods. So that can be a problem nutrient for elderly, where we don't really see protein as being a problem for most of our other age groups. Taste and smell also decline with age. What are the nutrition implication with that? A couple of other facts about that. We lose our ability to smell gradually in men around age 55 and women around age 60. Disease and medications, which are going to be more common the older we get, also can affect our taste and our ability to smell. So think about if you have had a bad cold and you're all plugged up and you can't smell anything, right? You usually don't really taste your food. And for most people, if food doesn't have flavor, they lose their appetite and they don't really want to eat anymore. And the other thing that can happen is in order to get taste, we overseason our food. And at least in the United States, that usually means more salt or more sugar, which are not typically what we want anyone to eat, much less an older person who probably has some health issues. Appetite changes as we get older. So this is talking about hunger and satiety cues. So right now, when you feel hunger, you probably notice it fairly quickly. And when you feel full, you also notice it and will stop eating. Those signals, which are actually orchestrated by hormones talking to from your digestive system to your brain, don't work well when we get older. So a lot of times you'll see people forgetting to eat, or maybe overeating and eating too much and not really realizing they've been eating too much. You can combine that with medications. A side effect of many medications is either um, increase or decrease in appetite. So you can kind of amplify some of these problems. And we see something similar with thirst. So right now, if you haven't drank for a while, you'll feel thirsty and you'll have a drive to drink water. Elderly don't notice or feel that thirst as much. And we know that dehydration occurs more quickly after fluid deprivation, and rehydration is less effective with advancing age. So we have a group who has to be really careful about hydration. And once again, there's a lot of medications whose side effect can affect that. So even something simple like a blood pressure medication, which sometimes makes you urinate a lot, can quickly lead to dehydration because of that. Other things that put someone at risk for malnutrition. So low income, low food and nutrient intake, functional disability, social isolations, where you live, depression, dementia, dependency, poor dentation and oral health, polypharmacy, minority, advanced age, and other diet or acute chronic diseases. That's a long list. Right? Think about all of these things together. Think about a person who is getting up in age, and I'll describe something that happened to my grandmother who passed away a number of years ago. I remember her looking through the obituaries and going to a funeral almost every week, and that was like one of her main social outlets, and got to the point where she was a very social person. She had so many friends, but she outlived most of them. I mean, how incredibly depressing that could be for someone. And think about, if you have a household, she had 5 kids and a husband and a full-time job, how busy you are, and now you're cooking for one person. It's more difficult to get to the store. You're on a fixed income. You used to be working and now you're not. Healthcare costs are pretty crazy now. Um, should definitely teeth can quickly become an issue. She was on a couple of medications. Some of them did dehydrate her. Um, she started to get hypertension. So they really start to add up and snowball. And it's really why I say this is a vulnerable population, especially for malnutrition, which is technically bad nutrition. You can have both over and under be malnutrition, but for elderly, we tend to see more undernutrition than we do for any other age group. So this big question I have at the bottom of the slide is, how do we identify who is at risk for malnutrition? Right? So I'm trying to make you think of the word screening because that's what we're going to talk about next. This is what we call the determine checklist. It's a nice thing to remember or take notes on because this is kind of a simple screening tool. So the letters of determine stand for these things, and they all mean someone could be at risk for malnutrition. So if they have a disease, they're eating poorly, they have tooth loss, economic hardship, reduced social contact, multiple medications, involuntary weight loss, needs assistance in self-care, or elder years above age 80. So when you screen for something, you go through a couple of things that might make you think, oh, they might have malnutrition. And once you go through it, if it turns out that, a couple of these are true, that would be a positive screen, and that would mean that person needs to go in and really have a full assessment. So screening's the quick and the dirty. Here's another well-known screening tool, the MNA, or Mini Nutritional Assessment. This is one, if we were meeting in class, we would have an activity and I would give you a case and you would figure out what someone's score is. So instead of using the determine checklist, it really gets at the same things, but you answer each of the questions and you write down the number and then you add up the number at the end, which is down here, sorry. So if you have a very low number, that would again be a positive screen. We'd be worried for malnutrition. And someone who scores low on this would need to go see a doctor, see a dietitian, see a social worker, do something because um, you don't diagnose someone with malnutrition, but you qualify them as very high risk based on this score. A true diagnosis would need a more comprehensive assessment than this. So, a couple points about screening for malnutrition in the elderly. What is the purpose of screening? Again, screening is quick and dirty. Who can screen? Just about anybody. It certainly doesn't have to be a nutrition professional. It could be, a diet tech or a nurse's aide. You could even probably hand it to someone and have them fill it out themselves. But the purpose is to quickly identify someone who might need more attention. So if the results are negative, that usually means that they probably don't have malnutrition. But if they're positive, they are going to need a referral. If the screen is positive, then it should move on to something more robust. So in the nutrition world, we do a full-blown nutrition assessment that's usually done by a registered dietitian. It's more comprehensive. You're trying to see if they do have a true diagnosis of malnutrition and any other nutrition-related problems and thinking about potential interventions. So again, who should do this? This should be a trained professional. And an assessment is not just asking a couple of questions about, um, weight loss and um, what you saw in some of those screening tools. We would do a full-blown anthropometric measurement where we really got a good sense of their weight and calculated their BMI and got a good weight history because unintentional weight loss is a very serious problem. Biochemical, we probably have lots of labs. We could be looking to see vitamin and mineral status. We could be looking for lipids, blood sugar, all those things that we commonly see problems with in the elderly. Clinical, we'd really want to know family history of disease, current diagnoses, hypertension, possibly, all those things. Diet, we do a very thorough diet history to determine if their diet is healthy or not. An environment, that's where we'd get at, economics. Do they have enough money for food? Are they able to get to the store? Who does the shopping? Are they able to prepare food? Um, do they have access to health care? If you do this very thoroughly and correctly, a full-blown assessment often takes, up to an hour to make sure you're identifying any potential problems. Now, a common thing that I see students do, and you can think about this when you do your second case study, is they kind of look at a diet and they just sort of decide that it doesn't look good. They see that maybe there's a lot of processed food, so they'll say, excessive sodium intake. So if you really want to do a good job and be professional, you need to compare your analysis to a standard. So this just isn't a person saying, wow, that sounds like a lot of salt. This is having a standard and truly kind of adding it up and seeing if that person is meeting the recommendations. So a lot of people just do this by food groups. The dietary guidelines will recommend, often 2 fruits, 3 vegetables, half the servings whole grains, maybe 5 ounces of protein, 3 servings of dairy, right? It's fairly easy information to have. So if you just did a diet analysis on someone, you could compare what they reported for servings to what they should be having through the dietary guidelines, right? That would be the standard to which you're determining if the diet is adequate or not. Sometimes you want to be even more specific and you look at specific nutrients. So instead of just saying, wow, that's a lot of salt, you might look at the RDA for salt, and you know that the upper limit for sodium, the amount you're not supposed to go over is 2,300 milligrams. And if you added up the salt that that person consumed and it was over that, you'd have a very concrete standard to say, absolutely this person is consuming over the UL for sodium. You could also think more generally and just think about risk factors, especially when you're thinking about malnutrition. A lot of those would pop up from the screening tests. So, lots of different ways to be a bit more professional about how we are assessing someone's diet. Another common mistake that I see students make is when they're assessing someone's diet, they think that's just sort of reporting what the person eats, right? That's not an assessment, that's just describing or reporting. An assessment is when you really do assess and add up the calories and the grams of fat and all those important things, and figure out if they're really high or low in specific nutrients. And how do you decide which one of these three to use? It's going to be based on the information that you have, and what you think is most important. That definitely takes some higher level critical thinking to know that. But at the very least, know when you analyze someone's diet, you truly do analyze it and try and determine based on a standard if something's too high or too low. Now, some other standards you can use are any sort of well-respected recommendations about nutrition. So, AND is the Academy of Nutrition and Dietetics. SNAP is, most people know that as food stamps. Tufts University has a USDA research center on aging and nutrition. So all of these groups will put out recommendations. Usually they're based off of the dietary guidelines, but they've been adapted for older adults. But this is useful, right? Because older adults do have unique nutrition needs. So sometimes when they do it for an older person, they'll make more specific recommendations about fluids and water because dehydration is so common. Sometimes we'll talk specifically about vitamin and mineral supplements, especially the nutrients that elderly tend to be low in. A lot of times it's pointed out that elderly need fewer calories because we don't want weight gain, although, of course, we don't want unintentional weight loss either. And physical activity, especially with those strength exercises, are extremely important in aging. And fiber, keeping your digestive tract healthy. So it's actually easier just to see an example. So this is my plate, which you're probably familiar with, but we do have a version for older adults that would be good if you're, again, need a standard to kind of assess someone's diet. You could easily go to their website and find out exactly how many servings a person would need based on their age and gender and activity level. And you'll notice that the pictures are meant to say stay active, and they're meant to show someone who's supposed to be older, and they have these extra messages that you wouldn't necessarily have in a regular plate. But these are specific nutrition recommendations for older adults. I'll point out that the micronutrients they mention are vitamin D and B12. Those are two that are very, very commonly deficient in older people, and we almost always recommend supplements for them because it's very difficult to get it through food alone. Other nutrient recommendations, they change all the time. We're going through another round of looking at the dietary guidelines, and that's really based on science and research and as we understand the human body better and how food affects human functions. To give you an example of that, you know that the DRIs, the dietary reference intake, that's where they have all the nutrients and the recommended amount based on gender. but they started being very specific by age group as well. So in the 1997, they gave new DRIs for people over age 51. And sometimes we even split it up even more specifically than that. We also know that energy needs decline. We tend to be less physically active. Our basal metabolic rate declines because of that change in body composition. So, elderly adults usually need about 20% fewer calories than they did when they were younger. And if you think about that, where should those calories come from? Most of us as younger, hopefully active people can get away with what we call discretionary calories, so junk food, and that is okay, and it's not going to impact us too much. When you think about cutting out 20% of what you eat and still meeting all your nutrient recommendations, that basically means you don't have a lot of room for junk food anymore, which isn't all that fun to think about. So I know I myself want to keep up my activity so I can still have some ice cream when I'm older. Priorities. Thinking about macronutrients, so carbohydrate and fiber, I always show this kind of weird picture of Hulk Hogan. Um, the AMDR for carbs does not change. It's the same for adults and elderly. Neither does the fiber. It's actually a little bit lower because fiber is based on calories and older people consume less calories. But we tend to not meet the fiber recommendation ever, and certainly not when we're older as well. So constipation is extremely common in older people. So fiber would be a nutrient that would be very beneficial for them, not only the soluble fibers that help with your cholesterol, but the insoluble fibers that help form your stool and make it easier to pass your stool and prevent constipation. We see constipation because our digestive system slows down with aging, and we also tend to drink less fluids and be less active. So it's kind of this perfect storm for constipation. Um, Another reason why I show this weird picture is because I heard this on the radio once. I looked it up to see if it was true. A disproportionately high number of people, usually older men who are high risk categories for heart disease, die on the toilet. This is at least partially due to problems some older men have with constipation. So, if that's not a good reason to keep your fiber and fluid and activity up, I don't know what else is. Protein's an interesting nutrient to talk about for elderly. The recommendation is the same. It's zero point 0.8 grams per kilogram, but that's actually very somewhat controversial. We also know that unlike our other age groups, intake is more likely to be low in older people. Like we talked about, it's harder to chew, it can be harder to prepare, it also tends to be expensive. A lot of researchers do want us to raise the recommendation and feel like for elderly it should be 1 to 1.3 grams per kilogram, and that would be to try and prevent some of that loss of lean mass. So figuring out how much protein an older adult needs can actually be somewhat complicated just because of that. Based on height and weight, how much protein will meet individual needs. So you have to think a little bit deeper than just, oh, zero point 0.8. You need to think about total calories in the diet. If you don't eat enough, your body has to use what's stored for energy. And if it's using your lean mass, that's certainly going to be a bad thing. So if calories tend to be low, you absolutely need to be having good high quality protein to help ensure that you're not using your lean mass for energy. You also, again, have to think about the quality of the protein. So high quality proteins contain all the essential amino acids, and those are going to be better utilized by the body. So, it's one of those areas where meat protein is probably beneficial for some elderly people because of this. You also have to think about, again, if you need more than zero point 0.8, if there's any sort of other health issues going on, especially wound healing, tissue repair, surgery, fracture, infection, anything that needs recovery, you will need more protein to help with that. Is the individual exercising? So nitrogen balance is the best way to know if someone's protein status is good. Um, if someone is more active, they will be more likely to be in nitrogen balance, so that's a good thing. So if someone's inactive, it's not somewhat counterintuitive, but they actually means they probably need even more protein. Fats and cholesterol, um, we need to keep our saturated fat low. The general recommendation is 10%. If we're higher risk, it should actually be less than 7%. And keep our fat between 20 and 35% of calories. I always throw this question in there because, again, elderly tend to be complex. If someone has a history of heart disease but is experiencing malnutrition in the undernutrition realm, what's more important to treat? The malnutrition or keeping their saturated fat and fat low? Here's a case where the malnutrition, if they're not eating enough, is more dangerous than the heart disease, which is a chronic disease. So if the only way you can get someone to eat is to give them maybe more fat or saturated fat than this recommends, you should do that just to make sure that you get them out of the malnutrition world. And give you kind of an example too of a specific food. So a lot of people didn't like eggs for a long time because the yolk in eggs have a lot of cholesterol. Um, but now we know that cholesterol in foods really doesn't impact our blood cholesterol very much. And we know that eggs have a lot of nutrition. They're convenient. They have good, high quality protein. They're pretty easy to prepare and they're not very expensive. So, if you thought, oh, I can't tell someone to eat eggs, they have high cholesterol, they have heart disease, um, that's really not true. Eggs might be a really important food for someone to have, especially if they were having malnutrition. Recommendations for fluid. Remember that dehydration is really important. We know body water is decreasing with age, and that means that there's a smaller margin of safety for staying hydrated. We said the same thing about infants, so we're kind of coming full circle here. 6 glasses a day will prevent dehydration. If you want to be more specific, you really want to figure out how many calories someone should be consuming. You can use one of the equations like the Mifflin St. Jeor or Harris Benedict and have 1 ml of fluid for every calorie they need with a minimum of 1,500. But absolutely, with elderly, always be making sure that they're staying hydrated and having at the very least 6 glasses of fluid a day. All right, we're going to take a break here. So this is a long lecture slide, and I'll pick up in part 2.